Hey guys, welcome to our lesson on diseases of the ears, eyes, nose, and throat. Commonly refer this as to ENT, as we're dealing with most common issues associated with ears, eyes, nose, and throat. Let's go ahead and jump into this lesson. One of the things that's interesting about this lesson, or this chapter from the text, is that we know the head and neck itself contain many of the body's essential sensory organs and important structures. Numerous medical conditions and injuries can affect the head and the neck and other associated structures. This is particularly true in cases of the pediatric patient. We also know that many of these conditions do not readily fit into any of the previous lessons that we talked about, so it's kind of a mixed bag as we wrap out the last chapters of our Volume 3. One of the things that's important here is that the numerous important structures that are contained within the head and the neck are going to include core things like the eyes, the ears, the nose, the throat, and then any of the other components of the associated structures. And we'll dive into that a little bit more here as we go. We know that eyes are an organ of sight. They're going to be gathering light, and they're going to be focusing it into receptors in the back of the eye in order to produce an image that's received by the brain. Oftentimes you're going to see these things, and you're actually going to see that it's going to be flipped over. The image will actually be flipped from upside down. We'll talk more about that in a little bit. We're going to deal with both external and internal issues when it comes to the eye. Let's focus primarily on internal to begin with. It's protected by bones. These are the ocular orbits around the eyes that's actually helping protect the globes of our eyes. We know that the orbit is padded with subcutaneous fat tissue that's going to cushion and help protect against any type of blow or injury to the eye or to the face. And then it also allows for us to have movement, right? We know that in order for the eye to have movement, we have to have extraocular muscles that are going to allow for us to be able to look in all the different directions that we need to. And then we also have to recognize that there's two movable folds of skin, which we would easily refer to as eyelids, that protect the eye from its environment. Eyelashes are another component of that to help get rid of any of those extra components that may get into the eye. It also serves as a sensory mechanism as well to help with rapid blinking and closing of the eyes to clear any type of debris. Last but not least are going to be your glands. These are going to secrete an oily substance we call sebum onto the eyelids that are going to keep them soft and keep them pliable. This is if you ever get really tired and you feel like you're rubbing your eyes, like, man, my eyes just feel like they're greasy or heavy. That's what we're talking about with those glands secreting that oil. We also know that there's the membrane or the conjunctiva, which is going to cover and protect the eye surface itself. Each eye also is going to have tear glands, lacrimal glands, or lacrimal apparatus that is going to manufacture and store tears. Again, tears are designed to help flush away any debris, keep the eyes moist and lubricated for normal function. Tears are manufactured in the lacrimal glands, and they spread across the eye where they, again, will drain through the lacrimal duct. Not only out as a tear, but also internally into the sinuses as well. That's why if you ever have someone that's crying or they've got allergies, that's where that postnasal drip comes in as well. Here's an example of what you would see with that. If we take a look here, and let me put my laser pointer on, you can see here's that lacrimal gland. There's the excitatory ducts that are going to come down through here. Here's going to be the lacrimal papilla, which is going to be the primary area where we get tears that are coming from. They also can come down here through the lacrimal sac, and then they can drain down through that nasal duct as well and create secretions and things as it drips out the nose. Now, when we think about the ears, we also have to recognize that there's internal anatomy of the eye, right? So that was our external structures. Now we're going to focus on the internal. The globe has two distinct fluid-filled cavities. The posterior cavity, which is the first one, the portion that lies just behind the lens, and that's what contains the vitreous humor, or the fluid. The vitreous humor is a clear, jelly-like fluid that fills the entire vitreous cavity, right? So it's what gives the globe its shape. And then the anterior cavity is where the portion where we think of the lens that actually covers the eye itself, or covers the globe. And this contains an aqueous humor as well, which is another type of fluid that helps keep things moving clearly and helping your eye actually be able to focus. We also know that aqueous humor is water-like fluid. We talk about it, right? Surrounds the pupil, surrounds the lens. The anterior cavity is actually divided into different chambers, both an anterior and a posterior chamber. Kind of sounds redundant, but that's what it is. And both of those chambers are going to be filled with that aqueous humorous fluid. Now, when we think about the internal anatomy of the eye, the innermost layer is the retina. We're going to break this down a little bit more as we go, but let's at least identify them. We have the retina, the middle layer is going to be your choroid, and then your outermost layer is your sclera. The sclera is a very tough, fibrous protective tissue. It's what actually makes up the whites of your eyes. Again, very tough, very fibrous, and it's meant to be more of a protective tissue. The cornea, on the other hand, is transparent. It's the curved portion of the sclera, and it's what allows light to actually pass into the retina. We also have the choroid, which is going to be highly vascular tissue that provides essential nutrients to the tissue of the eye, and also, again, it's going to contain the iris and the pupil. The iris is the actual part that you look at that gives your eye its ability to change size and diameter. We're actually checking the pupillary size. We're looking at the iris, and that's also the color portion of the eye. Now, behind the pupil itself, you've then got the lens, right? And the lens allows for us to be able to focus on incoming light based off images, right? So light refracts off substances. Your eyes pick up that reflection, and then it creates it into an image or a message, right? The ciliary muscles that surround the lens actually change the shape of the lens itself to be able to focus, just like you would if it was a camera. You may have to rotate the focus on your zoom lens to be able to get it to focus or rotate it out. That's really what that's doing. The retina itself is going to be the primary component, which is going to be containing nerve endings, and it's the portion of the anatomy that receives and interprets incoming images, right? So one of the things that can happen oftentimes is someone can have damage to their retina or retinal detachment for specific types of trauma and things of that nature. Those are going to be where the nerve actually is separating from the globe portion or the structure of the eye. Now, the other part we look at with the retina is we know that it contains two different types of light sensing receptors. We call these rods and cones. You probably have heard that before. Internal anatomy of the eye, the retina, it's going to contain two different types of light sensing receptors, rods and cones. Now, rods and cones work differently depending on the type of light source. Rods are effective in dim light and do not perceive color. Cones, on the other hand, are much more effective in bright light, and they do perceive color. So one of the things that we can easily determine, especially when someone has issues with color blindness, is oftentimes it has more to do with their cones than it does with their rods. Now, chemical changes are going to be a part of this process as well. These chemical changes are going to send impulses to the optic nerve and then into the brain where that image, right, that ability for bright lights and dim lights and colors can all come together for the brain to actually interpret an image to work off of. Here's another example of all the things we just talked about. You can see right away that here's going to be our primary globe. We have the anterior chamber. Remember that the anterior chamber is divided into both anterior and posterior. If we look at the posterior chamber first, here's the vitreous humerus or liquid filling of the globe itself. Here's that choroid layer we talked about. The retina itself, the sclera is going to be that back tissue. It's on the back of the eye and all the way into the front. We talked about the optic nerve being at the posterior side, and then the central retinal artery and vein that supply that blood flow. One of the reasons why we see blood flow or eye issues, vision issues in patients who are diabetic or have chronic hypertension, those types of things, or even high levels of cholesterol, is it does affect those retinal arteries and veins. Here you can take a look at the lens itself. The lens is going to sit just posterior to the pupil. You're going to be able to see this aqueous filling here. Again, another liquid area filling. And then the pupil will lie just above that. Iris is going to be the opening, which constricts and contracts. You're going to see that there. And then the rest of these things, the lower lid, some of these additional posterior chambers we talked about before, the anterior chamber, those different components. Now, there are a number of medical conditions that exist with the eye. Most of these are not life-threatening and are going to have relatively the same type of care, but we'll go through each one individually to make sure we clarify. One of the first things we can deal with is what's called a stye. A stye is, in essence, not an internal issue, but an external issue of the eye. It's an infection of the eyelid or a blockage in one of the oil glands associated with an eyelash. In essence, it's like a little pupil on your eyelid. It's going to be located at the lash line. It's going to be a small pustule type, pus-filled lump, and it typically resolves itself once that gland blockage is relieved. Typically that's by warm water or topical antibiotics that can be used. The big thing with the eyes is we don't want to introduce any new pathogens, so trying to poke and pop things or relieve any of that pustule is not always going to be a good idea, but a nice hot compress will dilate those glands and allow for that hopefully to release on its own. Another one that we look at, Chalcin, is another one that we can talk about. Really has a lot to do with an internal blockage or internal damage. Mostly it's going to be based off inflammation or infection or some type of blockage in one of the glands of the tarsal plates of the eyelid. Most of these are going to be based on glands that are going to be blocked. You're going to see, in this case, you're going to see a red tender lump in the eyelid or in the margin, and the treatment is going to be similar to that to a sty. We cannot determine pre-hospital-wise between an internal block or an external block, like a sty. Conjunctivitis is another one that we typically deal with. Conjunctivitis is going to be an infection or inflammation of the conjunctiva. Typically, we think of this as pink eye, right? Bacterial conjunctivitis is where you get some type of bacteria in there and it grows and it creates that crusty, nasty pink eye that we typically deal with. It's localized, it's limited to the conjunctiva, right? So the cornea itself remains nice and clear. But we do see a lot of redness and itching and typically more tears that produce. And the problem is it spreads from one eye into the next eye. And so oftentimes with treatment, they're going to be done so through topical antibiotic ointments. And it's going to be used to not just treat one eye, but typically both, because the likelihood of spreading it is there. And it's extremely contagious. Here's an example of what that looks like. When kids get this all the time, they touch something, they touch their face, they diapers, that type of thing. Even parents can get this. Typically, there's going to be some pain, redness, soring, and then they'll wake up and their eye will be either shut or like almost like glued shut with copious amounts of this nasty like secretion type fluid. And so what that's going to make it very difficult for the patient to see. But a hot compress, a washcloth, something along those nature will be helpful as well. The big question you're going to want to ask yourself in this is the infection going to be, is it an infection or are we dealing with some type of inflammation? Infection is typically more common. Viral can happen as well, but the spread is going to be similar to that of bacterial. If the cause is viral, there's not a whole lot that we're going to do for it besides monitor and watch and then treat based on symptoms. We also know that if we're dealing with inflammation of the conjunctiva, we can have allergic conjunctivitis, which is exposure to pollen and allergens, which if the patient's allergic is going to cause redness, watering the eyes, itching, and swelling. The typical things we see with seasonal allergies, and typically you would treat them with oral topical treatments or other antihistamines, right? Your regular over-the-counter antihistamines or allergy medications. So the next thing we look at is what's referred to as pernicium. In this case, this is a conjunctival condition where we're going to see raised wedge-like shape growth of the conjunctiva. It's a non-cancerous and readily visible over the white sclera, and it can sometimes extend over the cornea and invade the visual axis of the eye. Although the cause of this is really unknown, it's more common in people who have an increased outdoor exposure to the sun, wind, and dust. So we see it more common in southern climates, along where we typically won't see it in children. It's more rare in that circumstance. Generally, again, no treatment is primarily indicated for these patients. Iritis is another one that we see. It's also called uveitis, and it is swelling and irritation of the middle layer of the eye. It consists of the iris, and uveitis is most often seen in patients with pre-existing autoimmune diseases like RA or rheumatoid arthritis, and other certain types of infections we may see. And associated with other conditions like AIDS and things of that nature. Signs and symptoms are going to include things like blurred vision, eye pain, photosensitivity, redness of the eye, and occasionally the appearance of floaters in the eye. Treatment usually includes protection from light, maybe some management of some pain, things of that nature. Right? Primary components of general eye care. Herpes simplex virus, or HSV, is an infection and inflammation of the cornea. Again, it's based by the herpes simplex virus. This situation can actually lead to serious blindness, and believe it or not, can actually lead a patient to be in the need of a corneal transplant. Most of the way it's going to present is going to be associated with pain, photophobia, so light sensitivity, blurred vision, tearing, and then redness of the eyes. Herpes zoster epidermidis is another one that we would see. This is the herpes zoster virus or the shingles virus, and it's where it gets into the eye. Again, very dangerous because it can spread very quickly to the first division of the trigeminal nerve, and the damage can result in damage to the eye and similar lesions to the cornea, losing permanent sight. Corneal ulcer is another component we deal with the eye. Infection, again, by the cornea, this by some type of infectious agent where it breaks through the epithelial protective layer of the cornea. Serious and sight-threatening infections because it is getting into the center, most dangerous component of the eyeball. Most of these viral infections are treated differently than bacterial infections, right? So we're not going to see the exact same approach every time we deal with this, but primarily we're going to need to get them to a location where there's going to be some type of evaluation by an optometrist or an ophthalmologist at least. Cellulitis. We all know about cellulitis pretty regularly. The soft tissue that's surrounding the eye can become infected, obviously resulting in cellulitis. It can be both sight-threatening and life-threatening, believe it or not. Cellulitis around the eyeball is typically classified as periorbital or orbital. And really we're talking about all those components, right? So we're going to see edemas around the eyes. We're going to have a lot of redness. We're going to have a lot of drainage coming from the eye and around the surrounding tissue. But here's the deal. The eye itself is generally not involved. Periorbital cellulitis, right? In this case, usually it's going to be a bacteria, more of a risk for kids like we talked about when we dealt with pink eye earlier. Patient's going to present with a significant amount of pain, conjunctivitis, right? That's that pink eye, blurred vision, increased tear production, components of that nature. Treatment, we want to get them antibiotics, and most likely they're going to require hospital admission to get that under control. Orbital cellulitis, this is the postseptal component, most serious infection we deal with when it comes to cellulitis, because not only is it affecting the eye, but it's affecting the structures behind the orbital septum. So now we're getting complications of the periorbital cellulitis in the sinus that may become infected. We see this very common in winter months. Common symptoms you would see: fever, headache, eyelid edema, so swelling of the eyelid itself, runny nose, generalized malaise. Orbital cellulitis, this is postseptal again. We're not talking about protrusion of the eye, inability to move the eyeball because there's some type of infection or swelling. Pain in this case is going to be associated with any type of eye movement. You're going to see a decrease in vision and inflammation of the conjunctiva. This will require hospitalization, significantly strong antibiotics, potentially surgical drainage, which is never good to have done to your eye, and truly is an emergency. Hemphema is another one that we see. This is where we get a collection of blood in the anterior chamber of the eye. Normally it's a result of trauma. It can happen in non-traumatic situations as well. Sickle cell disease is a big one that we would see, diabetes, and then if they have any type of tumor or growth in the eye as well. This is a sight-threatening condition and requires evaluation by ophthalmologists, and so you're going to want to make sure that's in the back of your mind. But in this case, we'll give you an image of that here in a little bit, but the idea behind it is it's going to cause a significant amount of blood to fill the eye. Glaucoma. Glaucoma is another component we deal with, right? This is grouped in the eyesight-threatening condition, right? The category of conditions we would group with that. But it's not something that's going to happen immediately. It takes a significant period of time for glaucoma to develop. In this case, we start to see increase in ocular pressure, and that ocular pressure within inside the eye actually causes damage to the optic nerves, which can cause blindness, especially here in the United States. Second leading cause of blindness is related to glaucoma. This can also be not just because of high pressures, but it can also deal with a blockage which will lead to the high pressures, a blockage of flow of that aqueous humorous fluid being able to drain out. If it can't drain out, pressure is going to continue to rise. You can also have false high interocular pressure because you may have a thicker lens in your eyeball as well. Angle closure glaucoma, this is where we have an excessive outflow of humorous fluid which is now suddenly blocked. It causes a rapid and severe increase in interocular pressure. That rapid increase leads to potential damage to the retinal nerve, and when that happens, or the optic nerve and the retina, when that happens, blindness can be almost immediate if it's not corrected shortly, permanently. We know with open angle glaucoma, there's no symptoms, but they all of a sudden begin to just lose their vision. Now, angle closure is a little bit different than open angle. Angle closure is going to refer to the development of severe pain in an affected eye, decreased or cloudy vision, red and swollen, rainbow or halo light effects around your vision as well too. So you'll see like these glowing arcs in your eyes as well. Regardless of what you're looking at with glaucoma, the main thing is to make sure that you're getting a good focus history on it to be able to recognize it. Cataracts. Cataracts are going to be a clouding of the eye lens. It's associated with aging or breaking down of proteins within the lens itself. It's normally brought on by pre-existing conditions like diabetes or maybe an eye injury, smoking, or being exposed to excessive amounts of ultraviolet light, including excessive sunlight. Now, cataracts are interesting because they do decrease vision. They cause this cloudiness or fuzziness that exists. We lose loss of color intensity, and then anytime we see light, we get this big halo or ring around a majority of lights. The real treatment for cataracts is prevention. They can surgically remove them. They actually take a slight layer off the lens to remove those proteins that are damaged or the structure that is damaged, and that will help. But generally, your primary treatment is prevention or surgery. Here's an example of what that looks like. You can clearly see this has a very large amount of that white cloudiness that goes along with cataracts. Again, these can be surgically corrected, and a lot of patients will go through cataract surgery. It may be one of the more common leading problems that we see based on infection or other components after they've had some type of intervention or surgery to the eye. Other medical conditions, now you can have optic neuritis. Optic neuritis is inflammation of the optic nerve. It results based on autoimmune diseases, infections, drug toxicity, or even MS. We typically will see this present with a loss of vision in a single eye in an hour, right? So you're going to see a very quick loss of eyesight in one eye, or loss of color, or any type of component related to the two. You may also see changes in pupillary reaction to light, and then pain as the patient tries to move or to track. Now with optic neuritis, vision returns to normal within 2 to 3 weeks without treatment. That's the cool part about optic neuritis. We've got to get the inflammation under control. Once the inflammation is under control, vision will typically return. So corticosteroids are going to play a big role in that, in helping us reduce some of that inflammation. And then they're going to need to see an ophthalmologist as well, because that a continuous assessment and long-term treatment plan is going to be necessary. Papillary edema is another component we see with medical conditions of the eye. It's really not a condition per se, but more so swelling of the optic disc based on some other traumatic injury leading to an increase in intracranial pressure. The optic disc itself, that's going to be the region of the retina where the fibers of the optic nerve are going to enter the eye, right? And so when we deal with damage to that component, either because of increased intracranial pressure or some secondary injury, mostly we're going to see it being associated with trauma, infection, strokes, and tumors, and hydrocephalus, right, swelling of the brain. Anything that would lead to a likelihood of an increase in intracranial pressure. Again, trauma, infections, stroke, tumors, and then this enlarged hydrocephalus of the brain. Another one we typically deal with would be central retinal artery occlusion. So now we're talking about a blockage in one of the small arteries that supplies the retina. And it results from either some type of clot or thrombus or some type of plaque buildup, atherosclerotic plaque that breaks free and clogs that small artery. Mostly you're going to see this associated with clots. They've got a clotting issue and all of a sudden we get a clot. Very common in diabetics. We know that their arteries are going to harden. They're going to have more long-term damage because of that. Patients with arrhythmias or those that have some type of valve disease as well. And if they're using drugs, if they're intravenous drug abusers, this could be another component that we see, which is that blockage of that retinal artery. Symptoms for retinal artery occlusion involve all or part of one eye and can last from a few seconds to a few minutes. Now, here's the deal. If the blockage isn't corrected, it can be permanent, right? Most of the treatments you're going to see are going to be fibrinolytic therapies to break up any clots. That's the most common. And then, believe it or not, actually massaging the eye. Blockage of these small veins. So that was arteries we were talking about. Blockages of small veins that drain the retina. These are typically damaged or blocked by some type of atherosclerosis or a thrombus as well. Again, common in diabetics, those with hypertension, atherosclerosis, and other eye conditions like glaucoma. Typically, if you see someone who's having diseases of the eye, it's going to be more than just one disease. A lot of times they're going to go hand in hand with a multitude of others. With central retinal vein occlusion, again, symptoms, sudden blurred vision or loss of vision in all or part of one eye, and then they regain vision without treatment, and typically it rarely returns to normal. It's not a typical thing where it's going to just pop back on, but it can. Retinal detachment, another component we see. This is where we're getting separation of the retina from any of the supporting structures, right? Could be from any reason, unknown cause, trauma, it could be diabetes. The way it presents is going to be bright flashes of light in their peripheral vision, right? So you get these flashes of lights here on the sides, or they're going to see these distant floaters kind of floating throughout their eyes. Another example of a potential retina detachment. One of the things that they definitely look for in glaucoma patients and then cataracts as well, because they both can be so closely related. If we have a patient who suffers from a retinal detachment, you're going to have where they're going to see shades pull, right? You're going to see shadow or blindness on part of the visual fields that affect the eye. It's typically treated surgically in order for it to be corrected. Those are the primary components that we were talking about in dealing with our eye injuries. I know it's a very fast way of going through it, but we'll now move on to the ear. So when we think about the ear, we know that the ear is an organ of sound. Sound waves are picked up from the environment. They're brought in through the ear, and they're interpreted by the brain, and it definitely plays, we know that the ears themselves definitely play a huge role in maintaining its balance and equilibrium. Now, as we look at the ear, one of the big things that we're going to have to kind of recognize here is both internal versus external ear, right? We're going to start with external, and we'll move our way in. The external ear we refer to as the pinea, which is going to collect the sound waves, right? It's going to direct them down into the auditory canal through the external auditory medius to connect to the tympanic membrane. The tympanic membrane is your eardrum. The external auditory canal is going to extend all the way from your out of your ear all the way into that tympanic membrane. At that tympanic membrane, we're going to move from external to internal. We'll talk more about that in a second. There's a lot of different protective substances inside the ear canal. One of the big ones that we don't typically think of as a protective structure is earwax. Earwax is actually designed to stop things from going into your ear, and your ear is naturally going to try to spit out anything that will get in there through the formation of earwax. In case you didn't know. So here again is going to be the external ear that we're looking at. You can see sounds are going to travel down through. Here's the pinea here, right? Ear lobe is on the bottom. It's going to travel all the way down through. And then we get here to the tympanic membrane, right? The tympanic membrane, we're going to have a couple of different, we have the malleus, incus, and stapes, which are going to all be the little tools that we would see here. And then you can see from that point on, this is our middle ear, right, that we're dealing with. And then from there we get into the inner ear. Both of these, anything past the tympanic membrane we would consider to be more inner. But middle ear is another way of looking at those bones as far as hammers and things to create the sound waves that are picked up by the inner ear. So let's talk about the middle ear for a little bit. Auditory ossicles are going to be 3 small bones that are joined together to help amplify sound waves received by the tympanic membrane. We talked about the malleus, the incus, and the stapes are going to be the primary 3 bones that we're talking about. Now, the middle ear is protected with within that tympanic cavity, right? So it's connected to the pharynx by what we refer to as an auditory tube. And equalization of pressures are going to happen between your middle ear and your environment. So one of the things that happens if you go up in an airplane, you get that pressure, that popping, or maybe even you go down into a valley and move up off a road into a higher elevation. That equalization of pressure is where we're going to see that. And that equalization of pressure is really happening in our middle ear. That's why when it pops, sometimes it hurts. That's because it's irritating that tympanic membrane or potentially even rupturing that tympanic membrane. Now, the inner ear is separated from the middle ear by what we call the oval window. Hearing and equilibrium provided by specialized receptors within the inner ear, and it's protected by a bony labyrinth. There's just a ton of structures internally to help protect what we use to hear. Now, the bony labyrinth is surrounded by a collection of tubes and chambers. All these guys are going to be filled with fluid, and that fluid what helps us maintain balance and then be able to pick up on a multitude of sounds. Vestibules are those membranous sacs, right, that sense gravity and linear acceleration. They're going to be really what are going to help you as far as recognizing if you're moving forward or if you're getting pulled down or moved up. Semicircular canals are more sensory structures that detect rotation of your head. So as you turn your head, you get that feeling. The cochlear, these are spiral-shaped structures that are going to contain cochlear ducts of membranous labyrinths. Basically, they are actually what provide the actual receptors and perception of hearing or sound. Here you have an idea what some of those semicircular canals would look like. Here's an oval window. Here's a round window. There's a vestibule. The cochlea is this guy right here. The cochlear duct, you can see that actually exists right here. And the vestibular nerve, or the nerve endings, going to get sent off to the brain to be able to interpret what it had heard. A lot of conditions that we can see with of the ear. One of the biggest, somebody sticks something in there that's not supposed to be there, right? So foreign bodies in external auditory canal, not uncommon, especially with kids. And if they can go in any orifice of their body, they're going to stick it in there. Generally, they're placed voluntary, but we can see things like insects that can get in your ears. And then we also have to be aware that there's potential for pain and bleeding if there's damage to any of the inner ear. And if we're going to remove any component, we want to do it with minimal suction, just very gentle suction if we can, small forceps if you can see it, magnets potentially if we know that it's metallic, or we can irrigate it with warm water. Foreign bodies, anything that's going to be in the ear is going to lead to a likelihood of infection or trauma, especially if we're dealing with any foreign body, really, for that matter. The other part we have to recognize is not all foreign bodies are going to be easily removable. So if it's difficult to remove, we may want to consider filling that auditory canal with mineral oil or something along those specific lines, because if it is an insect that's in the ear and it's going to be what's leading to the infection or the irritation, the best way to get rid of it is to suffocate it. And if we put oil, mineral oil in the ear, it's not going to damage the ear, but it would kill any insects. We also know that with medical conditions of the ear, we can have dust that can become trapped. We can get blockages of the auditory canal, which is going to muffle or block hearing. A lot of these symptoms, when we're dealing with dust or trapped particles within the ear, you're going to see earaches, earplugs, ringing of the ears, tinnitus, hearing loss. And until that plug is removed, it's not going to get any better. So we need to have that removed either through, again, mineral or baby oil. Maybe they're doing some drops or detergent or even hydrogen peroxide. It is not recommended to do a hydrogen peroxide flush at home unless you're doing it under the direct care or supervision of your physician. Other infections, again, predominantly in children, Otis externa here is where you get swimmer's ear inflammation of the outer ear and or external auditory canal. In these cases, anything with external movement of the ear is going to cause a lot of pain. We can see things like pain, drainage, itching, or hearing loss, anything associated with that. But again, it's on the outer component. The otis externa, treatments for these, infection-wise, is going to be primarily analgesia to help make you feel a little more comfortable. They may consider topical antibiotics or anti-inflammatory drops. Most of these are going to be primary infections of the external ear, and it can, if we're not careful, it can spread in deeper, either into the inner ear, if it's from more of an external component, all the way into the spongy bone in your skull, as it actually can begin to actually get all the way into your brain if it's not taken care of properly. And it's really based on difficult to treat bacterial infections. Malignant otis externa is another one we can see here. External signs and symptoms for these guys: earache, ear pain, drainage, fever, difficulty swallowing, loss of voice, facial weaknesses. This is going to require hospitalization and antibiotic therapy. Very hard for us, again, to determine what really is going on with the ear. With otitis media, common condition, we get a blockage of the Eucharian tubes, which is going to be what allow for fluid to be able to drain out. Leads to typically it's based off a bacterial or a viral infection, and you're going to see common symptoms of an ear infection, right? Earache, signs of feeling of fullness or pressure in your ear, malaise, vomiting, nausea, diarrhea, anything associated with an infection. Chronic middle ear infections can happen as well. It's where they persist or they reoccur. And the more that it happens, the more often that this infection continues to reoccur or becomes more prevalent, the more likely that patient is of having permanent ear damage. Antibiotics are going to be required in this. They may also have to have some what they call tephnoscopy. I can never say that. Basically, they're ear tubes, right? Basically, what it is a little tiny tube. They could have slit into your eardrum, and they slip a little rubber tube through there, and it allows for decompression of that middle ear and any fluid to escape from behind it. It's very common, especially if kids who have chronic ear infections, things of that nature, they're going to be a candidate to get ear tubes. You can perforate your tympanic membrane. We know that the tympanic membrane is a very delicate structure separating the external from the middle ear. The membrane can be easily perforated by any type of trauma, foreign body objects, or even infection. Most commonly, I've seen this. I actually had my eardrum rupture, a tympanic rupture in my right ear during a flight. My ear didn't pop right. It was really bothering me. We were coming down. We started to land the plane, and they took right back off immediately. When that happened, I had a super huge pop in my ear, a lot of pain, and then ended up having to go to the doctor, and I had ruptured my tympanic membrane. So it can happen. Other things you can see as far as perforated tympanic membranes, it's usually an acute onset of a problem based on the rupture. Most cases, there's not much they're going to really do. It's going to heal on its own, but they can cause some discomfort, so they may need some type of pain management, and then really focus on strategies to help prevent infection since the middle ear is now exposed. Here's a prime example of what that would look like. And here you can see, here's a tympanic membrane, and right out here there's that big blowout or that rupture. Mastoiditis is another one you can see. This is an infection of the mastoid bones, the base of the skull. The thing is, the infection can spread from your middle ear down into those mastoid bones. And it can, again, primarily affects children, but we see a lot of components with ear pain, drainage, hearing loss, redness and tenderness over the mastoid bone, headache, and then fever. Treatment primarily is going to be antibiotics and potentially surgery as well. Labyrinthitis is another one you can see. This is where we're going to have swelling and irritation of the inner ear. It occurs following, again, a middle ear infection or some type of upper respiratory infection, something dealing with primarily with your sinuses. You get a nasty sinus infection, you're going to have problems maybe dealing with vertigo or balance, involuntary eye movement, dizziness. You get this feeling that you're just spinning all the time, loss of hearing, and then ringing in the ears as well. Treatment for that is really going to be based on symptoms. A lot of it's going to be trying to make them feel comfortable, especially if they're having any issues with balance coordination, which can lead to a lot of nausea and vomiting. Meniere's disease, inner ear, again, we're talking about balance and hearing. So with this case, the labyrinths within the inner ear are very irritated. They're swollen. It's going to begin very acutely. We get a rapid onset of vertigo, dizziness, nausea, vomiting, hearing loss, usually on one side. There's really no known cure. There's a lot of people that have beliefs to put your head down for so long, or lift your head up, or drink soda sitting upside down. There's a bunch of myths as far as what you can do for it. But Meniere's disease, there's not a whole lot we can do. All right, so now we're on to the nose. So we've gotten through the ear, the eyes, ears, now we're on to the nose. The nose is another component of our sensory. In this case, we're talking primarily about our sense of smell. We know that the nose also plays more roles than just sensory. It's also going to be part of our warming, humidifying, and filtering any incoming air. Gives us our sense of smell as part of our olfactory receptors and part of our upper nasal cavity. You're going to be able to tell when the brain processes incoming signals. We smell. Oftentimes, smells can be more powerful for triggering emotions and memory than anything else. You ever all of a sudden had a taste that reminds you of a smell, or you walk in and every time you smell this one thing, you know what it is? Homemade cookies, GI bleed, something along those lines. It's going to be all based on that process of the signal in which our brain processes incoming signals, right? So when it processes the incoming signal, we can smell. Remember, the sense of taste and smell are very closely related. We see this with COVID-19. One of the common symptoms to a positive patient is a loss of sense of taste and smell because they are so closely related. Here again, we can see that cranial nerve number 1 is the olfactory nerve, right? That's going to be this guy right here. And that's what's going to be giving us that sense of smell. So as air is going to be coming through the vestibule, it's going to be passing the inferior and middle turbinates. It's going to be traveling down the posterior component, past the pharyngeal tonsils, and then here it's going to go down past the soft palate. Here's your hard palate, right? Here's your soft palate. It's going to go and travel on down through as you breathe in. But again, those olfactory nerves are the primary ones we're talking about. These structures are very high in vascularity. It's what leads to the majority of nosebleeds. Kesselbach's plexus is where we see 90% of those nosebleeds. I don't think that was actually on here. No, it was not. It must have been another slide coming up. Sinuses, again, as things are going to be traveling through your nose, that your turbinates are going to warm, humidify, and filter your air. Your olfactory nerves, the top portion of that, are going to pick up your sense of smell. And then you also have your sinuses, right? Your sinuses are air-filled cavities separate from the nasal cavity by mucous membranes. You have maxillary, frontal, there's a ton of them that you have. But the idea behind it is that those structures can easily become inflamed, they can become infected, and that can lead to a lot of problems associated with the nose. One of the biggest conditions we see with the nose, believe it or not, is epistaxis. That's a nosebleed. Secondary to minor irritations or upper respiratory infections, you can get an onset of nosebleed. Wearing oxygen at home without it being through a bubble or through a humidifier can lead to a nosebleed. Changes in the weather can lead to a nosebleed. We see it more commonly in the winter and those that are commonly on long-term oxygen without some type of humidifier or bubbler to add moisture to the air. Anterior bleeds come from Kesselbach's plexus, and posterior bleeds come from blood vessels further back in the nasal cavity. Much harder to control those posterior bleeds than it is for an anterior. Now, treatment, there's not much to a nosebleed. Simple pressure, enough pressure on the base of the nose where it's going to cause discomfort. We can see medications that can be utilized. Oftentimes you may see epinephrine used to help constrict those vessels if that's an issue. It's again an inter-hospital treatment. Cauterization, pinching of the nose, catheters, or what we refer to nasal tampons, right? The rhino rockets that go up in their nose and it creates pressure against the different bleeds. Pain, nausea, vomiting are probably the most common you can see. Nausea, vomiting is a huge one because if they're not leaning forward, letting the blood drain out, they lean back, put their head back, they're going to be swallowing that blood. Those blood clots inside the stomach are going to lead to vomiting and potentially aspiration. We can also see foreign bodies getting more common in kids. You can see where they're going to have a toy or bead or some type of crayon stuck way up their nose. You're going to hear them be able to whistle or some type of constriction that can happen as they're breathing. We also know that the treatment is going to be removing the object. Now that can be a little bit more specific. There's a lot of tricks of the trade out there, but primarily we would transport allow for a physician to remove that. Rhinitis, this is a great one if you're ever trying to get out of work. You come in and you say, oh man, I can't make it in, boss. I got a real bad case of rhinorrhea. And they're going to probably send you home. Rhinitis and rhinorrhea is in essence inflammation of the nose or a runny nose. We typically see this with upper respiratory infections, allergies, or other similar-like conditions. In infants, it's treated with humidification of the air and some saline drops. They use saline to break up any mucus, and they suck it out with a bulb syringe or like a nose-free-to vacuum. Nasal decongestants, antihistamines, and nasal corticosteroids are also used. That's more common in adults. We also can see when we deal with issues secondary to infection, inflammation, bacterial, viral, allergies, whatever it might be, you're going to see a lot of facial pressure, a lot of sinus headaches, throat, sore throat, posterior nasal drip, which leads to that sore throat, cough issues, bad breath because they're constantly swallowing mucus. That creates a lot of acid, and that creates bad breath. Loss of smell, malaise, or even a fever. Mostly you'll see if you're dealing with some type of sinus infection, antibiotics, decongestants, antihistamines, and steroids, corticosteroids are going to be your primary treatment. Again, not much that we're going to do for a sinus infection in the pre-hospital setting. Here's what you can take a look at. You can see that obviously there's going to be excessive amounts of mucus that's going to be inside the nasal cavity. You can see that here. And then as that happens, not only are you going to have that blockage here, but you're going to start to see these sinuses begin to fill with that mucus. They're going to become very red and inflamed because they're infected. And that's a major issue that leads to the pain and the pressure that your patients have. All right, so we've made it through ears, we've made it through eyes, we've made it through nose, now we're on the throat. The throat itself is going to be the opening to the oral cavity, folks, not like you didn't know that. The entrance to the gastrointestinal tract, right? It's where you put all your food. It is a conduit also for respiratory gases, so we got to remember that not only is our throat important because we're dealing with the esophagus, we're also dealing with the trachea, and then a lot of the different senses that we deal with as far as analyzing substances before swallowing or the actual mechanical process for chewing food, any of that part and process for mastication. The throat, when we think of it, we've got a couple different areas that we break it down. Let's talk about the anatomy first. We have the labia, which is your lips, right? You have your palate, which is going to be the harder portion of your mouth, your tongue, your pharynx, and the posterior portion you have your uvula. We talked about those. Here's an example of what that looks like. Here again, so you got your teeth, right? You got your tongue, or also referred to as the dorsum of the tongue. You have your tonsillar pillars in the back here. You're going to have your, so your tonsils are here, your posterior pillars are here. An example of those, both sides. Your uvula is the little guy that hangs down in the back. Not everybody has one. Your soft palate is going to be up here. It's that soft, flexible-like tissue just above the uvula. And then you have your hard palate, which rides above that as well. One of the things that we think about with the tongue has a lot to do with cranial nerves, right? So we have bitter and sour and salty and sweet. Again, these cranial nerves, one posterior 1/3, the anterior 2/3 are going to be here. Bitter is going to be more towards the posterior, sour to the side, salty in the middle, and sweet on the tip. That's kind of what you're looking at as far as those components. More of the components for anatomy, so we've got the tonsils and the adenoids, which we talked about, their teeth, saliva glands, the esophagus, and the larynx. These shouldn't be anything new to you. When we think about medical conditions, though, pharyngitis or tonsillitis is another one we think of, right? Pharyngitis is where we're going to have an infection of the pharynx. Infection of the tonsils leads to tonsillitis. It can be both viral or bacterial, and it leads to a red, swollen, sore throat. You may actually even see some types of pus that can actually be released as well, too, in severe cases. We oftentimes are going to see any type of your lymph nodes, your anterior lymph nodes you may have swollen. Headache, neck pain, nausea, and vomiting oftentimes will associate this as well. Viral infections resolve with themselves, right? They have problems, they have symptoms, they treat the symptoms, so pain, maybe some nasal sprays, some ibuprofen, whatever it might be, and it will resolve itself over time. Bacterial infections, this is where we typically think of strep, right? And that's where you would look in the back of your mouth and you go, oh, you got all those little white dots. Those are all little pustules that are filled with your white blood cells from fighting off that infection. And so we really know that we need an additional antibiotic to help fight that bacterium. It's also why we do the rapid strep test. Not we, but the hospitals do the rapid strep test to be able to determine if it's strep positive, because we know that it's going to be more likely to respond to antibiotic treatments. Oral thrush, candidiasis is another one you can see. Candidiasis, I can't ever say that, but oral thrush. Mostly it's going to be fungal, dealing with yeast. You get a yeast infection of the mouth. Very common as far as kids. Infants, very younger, the more likely. They put everything in their mouth. It makes it more likely that they can get the yeast infection. Especially patients who are also diabetic and have a problem maintaining their glucose meter levels. AIDS patients, and then anyone who typically, you can actually get oral thrush based off taking antibiotics, believe it or not. What you get is a white cream-colored deposit on the mucous membranes, the oral mucosa as well, and it's going to be very red and it's going to be very swollen. It's pretty gross stuff. Treatment, you got to get the offending agent out of there. There are some correcting risk factors, and typically they're going to use some type of antifungal agent in order to, like a rinse or things of that nature, to help get rid of that. On a more severe aspect of that is peritonsillar abscesses. This is where you get, again, a collection of that infected material, pus, that's going to be around the tonsils, and we see this very common with kids, right? And if they have a massive peritonsillar abscess, they're most likely going to need their tonsils removed, but they're not going to do that until they get the infection under control. That's done through antibiotics. And it can be all over the place, roof of the mouth, neck, chest, and lungs. That swollen tissue may actually block the airway, which leads to a life-threatening medical emergency. No airway, no patient. We also see things like chills or difficulty opening the mouth and swallowing, drooling because of the inability to swallow, and then things like facial swelling, fever, headaches, muffled voice, sore throat, tender glands, the jaw, and throat. A wide range of symptoms, but they're all related to that abscess and the blockage that it creates. Treatment, they're going to drain the abscess. They're going to do antibiotics. Mostly, again, that we're not going to drain the abscess ourselves, nor are we going to actually do antibiotics, but that's what the hospital will do. Our primary focus is on airway protection and treatment for hypoxia. If we need to suction, we can go ahead and suction with a Yonker tip, or just like the dentist does, give them the suction unit and say where you need it, use it. Teach them how to compress the port to create the suction and allow for them to be able to get that out on their own. Pain and nausea is another big common you can see, so analgesics or antiemetics may be indicated, especially if it's burst and they're swallowing any of that impacted material or pus. It can really irritate your GI system. Ludwig's angina. Oral bacterial cellulitis, right? So major inflammation. This is going to be on the floor of the mouth under the tongue. A lot of vascular area that way as well. Typically, you're going to see this after some type of dental procedure. So it occurs after an infection of the roots, or maybe even a mouth injury where it led to an infection. If they had a recent tooth removed or something along those lines, it's potential that there could be some remaining bacteria and it could develop afterwards as well. It does develop quickly, and the problem with Ludwig's angina is that the swelling can be so massive because of that rapid onset and that rapid bacterial infection that it can include the airway. Again, remember, that there's not a whole lot that we worry about with ENT components, but airway with the throat is really important, so it can be life-threatening if it leads to an occluded airway. We also know that breathing can be difficult. We can see confusion or mental changes based on hypoxia, fever, or neck pain and swelling. Oftentimes makes us think things like meningitis. Also redness of the neck, weakness, or fatigue. They may be excessively tired. They may have trouble swallowing, drooling, earache, and speech that sounds like a person that has a hot potato in their mouth. So they're going to be ha 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 ha. They can't actually keep their mouth closed to dictate or phonate any specific words. In severe cases, you may end up having to consider a surgical airway or cricothyrotomy in order to get past any of those blockages, if that does exist. That's a pretty rare occurrence, but when it does happen, your ability to recognize and perform the intervention immediately will mean the difference between life and death with that patient. It's cured with proper protection of the airways and appropriate antibiotics. It's not that it's not survivable, it's just the rapid onset and the airway swelling that it's associated with it is what puts the patient at the highest risk. Dental abscess is another component we can see. It really has to do with lack of routine dental care or restorative care, right? So they maybe have something break and they don't go in to get it checked, they don't get it figured back out. It leads to an internal infection and ends up becoming an abscess. Again, non-life-threatening emergency, but dental pain can be one of the most excruciating types of pain that people suffer from. So it's not uncommon for them to call an ambulance if they're really not sure what's going on. Big time things that we're going to be dealing with dental pain, we're talking about where like the exterior of the tooth is broken down and it's allowing sensitive nerves to be exposed to the environment. And when those nerves are exposed, that's extremely bad pain. Now that could be from trauma, someone gets jacked in the mouth, breaks the tooth, and exposes the nerve, or it could be because of an infection that's eaten away at the outer component of the tooth and drilled its way down into it, where now it's at the root of the tooth, and it's going to be leading to a lot of infection, a blood supply. It's dark and warm in there. It's the perfect place for bacteria and infection to be able to grow. Now, when we have these infections or abscesses, mostly you're going to be able to see them at the gum line, so you're going to do a little more of an oral inspection. There's not much that we can do to treat it other than try to manage the pain effectively and then treat the infection. You'll find that they're going to give things like Ultram as a common anti-inflammatory to help calm and reduce the inflammation for that nerve. And then beyond that, they're going to go ahead and do a lot of antibiotics because the infection is the biggest problem that's irritating the nerve. You get the infection under control, you get the nerve inflammation under control, then you need a dental procedure in to clear out the infection and potentially remove the tooth or the abscess. Foreign body. Somebody gets something stuck in their mouth or their throat, obviously it can obstruct their airway. Kids are a big risk for this because, again, young ones, they love to put everything in their mouth. We know that their oral cavity, the oral pharynx is very small in comparison to the size of their tongue. Their tongue takes up a lot of space. So anything that can get lodged past that, the airway structures get smaller and smaller as they get deeper into the individual, as they get into their lungs. Psychiatric patients are another one that you might see. Prisoners, another component you might see, and then those who do not actually have natural teeth. They can lead to foreign bodies, especially like if a part of a denture breaks off or a part of like a retainer can break off. Main thing, as always, ensure you have a patent proper airway, transport appropriately to wherever they can remove the foreign body. Again, we're not going to be removing these in the pre-hospital setting. Epiglottitis is another one that we see. This is inflammation of the epiglottis. Very serious thing, right? Epiglottitis is one of those things where kids, we typically think about this, but it can happen really almost to anyone. The problem with children is that little inflammation of their epiglottis can lead to a complete airway obstruction and a life-threatening emergency if we don't recognize and intervene as quickly as we can. We see presentations of fever, sore throat, tripod, drooling positions. We may also hear high-pitched stridor sounds. The stridor sounds are because of the enlarged epiglottis. The drooling is because, remember, the epiglottis is that valve that closes over the glottic opening of the larynx, allowing for fluids to travel down the posterior component of the neck and get it down into their stomach. But if that epiglottis is swollen, the ability for it to open and close for both breathing purposes and swallowing purposes becomes impaired. Hence the reason why they have to drool, because they can't swallow that secretions down. The main thing for this is to recognize it early because it can be very serious and protect the airway. Don't stimulate the patient if you can help it, and most likely it's going to be bacterial and can be treated with antibiotics. Laryngitis. We've all probably suffered from some type of laryngitis at some point. You have inflammation and swelling of the larynx. which leads to a lot of problems in your voice. You'll, in essence, lose your voice. This can be by a viral infection or drainage from any type of upper airway. Allergies can be another component, bacterial infections, gastroesophageal reflux disease or GERDs, pneumonia, chemical exposures. Any of those things can lead to laryngitis. The big thing with laryngitis is patients don't typically lose their voice unless they're having a chronic problem with drainage or something along those lines, or an acute issue. Maybe it's a fireman that removed his mask off in a fire and breathed in hot toxic gas. Maybe it's going to be someone that's dealing with GERDs, chronic GERDs, and they have excessive acid reflux, and that's leading to a wearing away of their vocal ability. Again, it's recognized by fever, hoarseness, and loss of voice. Fever is pretty much, I would say, more so on the rare side, but definitely hoarseness and loss of voice. Tracheitis, this is inflammation or infection of the trachea. Bacteria typically is what we would see, produces a very deep cough, dyspnea, fever, and stridor. Again, we're talking about upper airway primarily, tracheitis of the trachea, where we're getting it inflamed. We don't normally see these circumstances in our respiratory patients because those are lower airway components. Even though the trachea is definitely considered lower, we know that because it's such a large structure, it's not as easily impacted as some of our lower structures. But in tracheitis, that inflammation can cause a whole new slew of problems as that airway closes off, making it more and more difficult for that individual to be able to breathe. TMJ, or temporal mandibular joint. These are going to be problems with the joint between the temporal bone and the mandible bone in the jaw. Malocclusion of the teeth or orthodontic appliances can often cause this as well. We see it with difficulty in pain, biting, or chewing. They have a clicking or a popping sound. Not a big deal in an acute setting. One of the things you might have noticed, though, doing your OR rotations or doing any type of intubations is you may see the medic or the physician or the anesthesiologist ask them to open their mouth, right? We talked about the 3-2-1 rule. To be able to, can you open up your mouth to be wide enough for 3 fingers? And if you do that, do you feel any clicks or pops? If they have clicks or pops or have trouble opening their jaw, the question is then, do you have problems with TMJ? Because if they do, it makes it much more difficult for us to manage your airway. So, in summary, there will be a lot of instances in your career when you're going to encounter patients with something wrong with their ears, eyes, nose, or throat. The thing about it is some of those are going to be life-threatening, but not all of them. Most of them are going to require common general care, palliative-type care. There are a couple pre-hospital priorities, though. One is always protect your patient's airway. Pay close attention to their ventilation, especially if it's required, and then circulation, right? ABCs. Remember, no airway, no patient. And your ears, nose, and throat are all part of that first component of bringing air in to the lower part of the respiratory tract. Remember that once established, try to identify the cause of the problems and begin the appropriate treatment. We're not going to always have all the information or the proper testing to know exactly what part of the ear, for example, is infected. But we can begin to pick up on certain clues and lead down that pathway as we try to identify what that problem might be and then establish that proper treatment. You got to remember that in many circumstances, treatment is based on just their symptoms alone. Make them comfortable, treat their pain. If they're having more serious conditions, be more aggressive with your therapy. Pain treated with appropriate analgesia is always critical. Making sure that we also consider the use of antiemetics to help treat any type of vomiting or nausea. Because again, more vomiting or nausea may actually make the problem a whole lot worse. Other issues treated as directed by your local protocols. You're going to find there's not a lot of protocols when it comes to injuries to the eye. One of the components that is important for us to mention is tetracaine. These are eye drops. It's one of the few things that the state still requires us to do and to train on. Not every agency even carries tetracaine in their bag, but it's, again, if you have damage to the eye, tetracaine drops in there will help minimize any eye pain. Most of the non-traumatic conditions involving the ears, eyes, nose, mouth, and throat can be true emergencies, but with prompt recognition and treatment, you're going to be where you need to be. And so with this, guys, if there's anything else that you can think of with ears, eyes, nose, and throat, Remember this. One final word of advice. If you're dealing with the patient with any problems, the ears, eyes, nose, or throat, make sure that you focus primarily on airway, breathing, and circulation. Treat your patient's symptoms and get them to an appropriate center that's going to be able to have the proper follow-up. Also remember to educate your patient. A lot of the care that's necessary in order to prevent these injuries or illnesses is all based on preventative routine care. Proper hygiene, dental care, hearing care, and things of that nature. And that concludes our lesson, and I'll catch you guys on the next one.